The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, with another issue of the Genuine Article. And today I'm talking to Dr. Eva Laan, who's professor of medicine at McMaster University in Canada. And she's just completed a very interesting study called the STAR study, which addresses that very important issue of whether or not we can administer some treatment to patients with prediabetes to prevent the onset of vascular disease. We all know that the prediabetic population is increasing in our society. So tell us a little bit about the study, Dr. Laan.
Thank you. Yes, we had 1,425 participants without vascular disease and without diabetes, but what we call prediabetes, namely impaired fasting glucose or impaired glucose tolerance. These participants were randomized to Ramipril and to Rosiglitazone, and we measured the effect of these therapies using a surrogate, namely carotid intima media thickness, and treatment extended for an average period of 3 years.
So in this low-risk population, one would really have to go to a surrogate, even recognizing the limitations. Your feelings about carotid IMT, is that a good surrogate?
I believe that it is one of the quite well-established surrogates, obviously not perfect, but it does seem to predict quite well both myocardial infarction and stroke, and it has performed quite well in clinical trials, especially in statin trials, and especially in people with pre-existing plaques.
Good. Well, tell us, what were your findings in this trial?
Well, again, we tested two interventions for the blood pressure lowering medication, which is an ACE inhibitor. We saw a drop in blood pressure, but no effect, in fact, on vascular disease progression on carotid IMT. For Rosiglitazone, there was, as expected, a decrease in glucose and a very modest effect on blood pressure. We did see a trend, but not statistically significant reduction in the primary endpoint, which was a more composite measure of carotid IMT, but we did see a statistically significant reduction in a predefined secondary endpoint, which was looking only at the common carotid intima media thickness.
So you're looking at a reasonably healthy population without vascular disease and with just prediabetes. Was there much progression of carotid intima-medial thickening even in the placebo group?
No, in fact, progression was very low, and this is one of the problems with current trials. Progression seems to be lower than we anticipate in our study design. So from that perspective, even though it was a large cohort, it may have been slightly underpowered, but progression was very, very slow, 0.007 millimeters per year. So it was quite slow.
Was it your sense that had you followed these patients longer, or if you had treated them more aggressively, that you might have found more intense results?
I think so. As mentioned, there was a clear trend in the primary, and we had the positive secondary endpoint, and we also defined before unblinding and an additional endpoint, and that was also positive for Rosiglitazone. So I think the signal is there. Also, I think we should put it in context of other trials. We had some IVUS trials, both with pioglitazone and more recently with Rosiglitazone, showing also possibly modest effects on atherosclerosis progression.
So at this point in time, would you say, based upon your results, that you would advocate clinically that we treat our pre-diabetic patients with either Ramipril or Rosiglitazone?
I think that I would definitely not recommend it clinically for the prevention of cardiovascular events. In the parent DREAM trial and even in the sub-study, we saw fewer people developing diabetes in the Rosiglitazone arm, and this is questionable. But in terms of preventing cardiovascular events, I think that would be premature, and we really need more robust clinical trials evaluating effects on cardiovascular events with glitazones, with glycemic control in general.
Well, there's no question that this pre-diabetic population represents a real challenge to us because they are a definite risk of vascular disease, and we'll look forward to further work by you and your colleagues as to how we might be able to intervene to reduce that. Well, thanks for being with us. For the Genuine article, I'm Tony DeMaria.
The Genuine article. Discussion and commentary based on articles from JACC.